and call this budget work session to order. Thank you, everybody, for coming. As we get started, I want to acknowledge two VIPs in my life, Alicia Albernaz and Paul Albernaz, who are here for Bring Your Children to Work Day. Thank you guys for coming and for being so patient. And to all the children that we spent time with this morning, it's been such a magical day for them and such a special day for those families, and so it's a great day to be at work. All right, we've got a lot to get to in this packet, so Ms. McMillan and Ms. Yao, why don't we go ahead and get started?
The first item that you have before you today is the Health and Human Services operating budget for the administration and support services. And just as an overview, in this packet we usually do a little couple of overview things for the whole department, so we'll start with that, which is there's $323.5 million is recommended for the Department of Health and Human Services as a whole. And there is a table for you that shows the increases. Overall, there's a 2% increase in the general fund and a slight decrease in the grant fund, which is the net of the 1.4% increase. And the FTEs go up by just a little under 1%. I've just listed for you in a table on page 2 so you can see the department-wide adjustments, and this gives you an idea of the things that aren't requested by the department. The decisions are made in other places, but they cross across the whole department. So things like compensation adjustments and motor pool rate changes and those kinds of issues. But in a department as big as Health and Human Services, those add up to a significant amount, so it's about $7.6 million. And then with that, we would move into the actual administration and support services section. And for FY20, the executive is recommending $39.6 million for this service section. It's basically divided into 3 program areas, the Office of the Director, and then the Office of the Chief Operating Officer. And I would say a lot of contracts reside in the Office of the Chief Operating Officer, even for some of the other program areas. So that's why you see it's such a large number. And then the Office of Community Affairs, and that office has the Community Action Agency, several of the things that you'll talk about in your joint committee sessions like Head Start and the Test Center. And it also has the African American Health Program, Latino Health Initiative, and Asian American Health Initiative within that, as well as VITA, which is the Volunteer Tax Program, which Ms. Yao will talk to you about when we get to that part of the packet. Okay? And so in the
We have a quick question from Councilmember Rice regarding that matter.
So in our Office of Community Affairs, Linda, for that $10.6 million, that includes the budget for both the African American Health Program as well as the Latino Health Initiative and the Asian American Health Initiative, correct? What I would like to do is I'd like to see us actually, we've heard continually about the challenges in health disparities that we've seen, and I'm not proposing anything that's crazy or super aggressive here, but I think that, again, just a small increase in terms of what we may be able to do to help our minority health initiatives continue to do the good work that they're doing in affecting health disparities. And so I wanted to do something relatively small for each of our units. So $50,000 on the reconciliation list for each of the programs for AAHP, for LHI, and AAHI on our rec list, just to expand existing programs, not to do anything different. But would that be appropriate here, or is this later on in the packet?
So I have something, but we could just jump to it right now if you just want to do that.
Well, it's up to the chair.
Absolutely.
Okay, so on page, actually I think it starts at the bottom of page 9, but really you can just go to page 10 because the bottom of page 9 is really a description for you. So if you go to the top of page 10, you'll see the recommended budgets for each of the programs. I did want to say to you that OMB contacted me for the African American Health Program. There is an error, and I want to actually ask to track it on the reconciliation list for now, but he's taking it up with the executive. On November 27th, the council approved a special appropriation for the African American Health Program for some additional resources. Because that was done after the budget information had been initially loaded into the process for FY20, it didn't it got tracked for FY19, it's in there, but it didn't make it into the numbers that flow through for FY20. So there's about $150,000 not showing in FY20 for the African American Health Program. I would like to just track that on the reconciliation list so that we know that that's an issue, but it's actually an error to what the budget should be. So I did just want to say that. And then, but in terms of the executive recommendation from a policy standpoint, the executive has basically annualized, but in that sense flat funded, but annualized all the budgets in the programs. The programs run slightly differently. So for the last 2 years, the Latino Health Initiative and the Asian American Health Initiative requested additional funding to move from having their programs done primarily through contractors to having those people be merit staff. And so funding was put in the budget to make those staff merit, and all those positions that were requested have been converted. That was done finished in FY19. And that is one of the reasons why you'll see a larger percentage increase for those two programs, because those merit positions now have compensation adjustments attached to them. The African American Health Program has continued to choose to have most of their program done through a contract. And so in last year this time, we discussed that they too need some acknowledgement of that in their contract to help the staff in that contract, not necessarily parity with the compensation agreements, but more like we do with our other nonprofit contracts. And so the recommendation that I had for you here was to place $39,000 on the reconciliation list to have up to a 3% increase in the AAHP contract. And as we go back to the nonprofit contracts, that's consistent with that. So that would acknowledge sort of the differences in the structures of those programs.
So I agree with everything that you said, Linda, which would be smart of me. But let me just say that, and so from the compensation standpoint, I completely agree. And I think that that gives parity to some extent, whatever we could. Right. This is solely programmatic in terms of the programs that they're doing, focused on behavioral health, focused on diabetes prevention, focused on a lot of the other things that we're seeing that we know in a community that continues to grow, right? Whether it's our African immigrant population, whether it's our Latino and Hispanic population, and our Asian American populations, and with seniors and the work that Asian Americans are doing with seniors, specifically with a lot of our diabetes population, with our African American Health Program that are working with our seniors and their diabetes. It just makes sense for us to do a little bit more just from a programmatic standpoint. So in addition to what we see that you've recommended and the county executive has reflected in terms of compensation, which I support, I just think that programmatically us being able to do a little bit more in those communities would make sense. And so I'd like to move those 3 tranches of $50,000 for each of those minority health initiatives.
And I just would say it sounds like that we would then put that in their operating expense so that they could use it for either outreach information, contractual services, because you want that to go into a direct service kind of a model, correct?
You've got it exactly.
Okay.
Thank you, Linda. So, Mr. Chair, that would be my motion.
Thank you, Councilmember Rice. Couple of thoughts. One, I couldn't agree more that our minority health initiatives are doing very important work in the community and providing an important extension of county government. I've seen firsthand the great work that they're doing. I know on the contracting side, our African American Health Initiative was having some trouble with procurement, and so our office recently made a couple of phone calls, but that's a separate matter that we can follow up on. I do agree with the motion, but I'd like to get a little bit more information on what the programming would be for before totally signing off on the reconciliation. But I do agree that having it as a conversation within reconciliation makes sense, so I would support that motion.
And I can contact them and ask what they would propose to do with that additional funding. Is that okay? And then I would just say that one of the things why with this is I do think that once we have know who the new director of HHS is, then I would think that the committee would want to come back and have a discussion about what direction all this will take, especially within the equity initiative that spans across all of the sections of HHS as well as all of government. So I think I think that would be a very good thing to do in the fall.
Councilmember Glass.
Just on that point, I know a lot of the leaders of these initiatives and advocates of them have spoken with all of us. We've heard you, and I think the prudent thing to do is wait for a new director of HHS so we can engage in this larger conversation of where we need to go from here. So thank you.
Yes. Okay. So then going back to page 3, if that's okay? Okay. So the first actually is, as you know, as you're getting used to the budget, we go in the budget, the specified changes are from budget year to budget year, and sometimes just the way the algorithm works in the system, you get small things that show up as individual items, and then large things that end up in sort of these dense multi-program. But we generally go through all of the specified changes, and that's why that's what's listed in the packet. So the first one actually is a position transfer. This occurred during FY19. It's already occurred, but it's a change from the original FY19 staffing complement, and so it's reflected in the budget, and I would just recommend approval. Okay. In the office of the director, there's $190,000 of multi-program adjustments, and again, these just are reflective of several things like compensation changes, contract increases, variety of things. In the office of the chief operating officer, the first item is to adjust the budget for the Enterprise Integrated Case Management System, or EICM, and the Electronic Health Records System to address structural budget deficiencies, and that's $740,000. And I did just note for you, you're going to look at a few of these places in HHS where the executive has made recommendations to better align the budget with actual expenditures in certain categories. And of course, you'll also see some reductions that are reflective of actual historical expenditures as well. But in this case, I've listed for you the 4 that are really sort of additions and identified as structural deficit. And so I think in the case of EICM and EHS, which is what is before you in this packet, that you need to decide if you're convinced that there's a structural deficit, and then also if the deficit should be closed, and then how long you should take to close it, since it's a substantial amount of money. This project, EICM, took several years to implement. It allows for an integrated case management system, since we have an integrated Department of Health and Human Services, and that way people in the department can actually better understand how people are receiving services throughout the department. So in that sense, everything is really great from a policy standpoint. It did take several years to implement, and the costs have fluctuated, and some of the budget actions have fluctuated. And so I did just note for you that in the FY19 budget, we actually approved a reduction to the line item for EICM of $1 million, which was based on some realignments of contracts, but now you have before you a request to put $640,000 into EICM. The $100,000 is for the electronic health records. And so I've provided you with the information from last year, and I have suggested that perhaps we would close this gap over the course of 2 years if it continues to exist. I think it has fluctuated in cost. I do think the $100,000 that's requested related to electronic health records system as an increase is reflective of the contract. And so I'm recommending approving $420,000, which would be half of the EICM, and then the $100,000 for EHR, and that would be a reduction of $320,000 to the recommended budget. And I know the department will want to speak to you about that.
Ms. Buckland?
Thank you. Victoria Buckland, I'm the acting director for HHS. So with the integrated case management system, Linda is correct that the total costs post-implementation have changed over time. All of those changes, however, have been in the downward direction. So after go live, we've made a couple of different contractual changes to how we both host the system and how we organize maintenance and operations. As was noted last year, we changed the hosting algorithm that originally we had been essentially required by the state to host the system externally in the same location that the state hosts the CARES system, because we have interfaces with that system. The state had relaxed that requirement, and so we kind of jumped on that and brought the hosting in-house, which resulted in a pretty considerable savings to us. At the time, we had essentially requested both acknowledging the reduction that we had achieved in the cost, but recognized that we had gone into that situation with a deficit in funding. Part of that equation got accepted, part of that equation did not. On the maintenance and operations side, we've changed, again, the contractual mechanism for that. And so last year, previously we would have had $1 million deficit. That's been reduced now to $640,000. So we've continued to look for efficiencies in how we maintain and host that system. And we'll continue to do that. But these are the contractual amounts. I mean, we do have contracts for these at this point.
Thank you. I don't see any lights, so I think we'll support the staff recommendation without objection. I did have one comment regarding the note regarding surplus, because it's something I know a thing or two about, because budgeting these days is so challenging when you have to worry that there's the possibility of a mid-year savings plan, when you factor in that the Department of Technology Services and Department of General Services and Office of Human Resources have pushed many of those administrative functions out into the departments. And so particularly when it comes to departments that have facilities, you have to be careful and in some cases set aside some funds in the event that there is a fail in one of your buildings. And so I'm very sympathetic to HHS's comments here and just wanted to take them one or two steps further because I know how challenging it is in this environment to be able to move forward. And then the last layer, which we've heard repeatedly over the last few months, is the challenges that we've had within the Office of Human Resources have also had a cascading effect within departments and agencies and their ability to budget in real time. And so I'm very sympathetic to the note that was written here.
Yeah, and the other thing to simply keep in mind is that for a department of our size, being off by 1% is still more than $3 million. And so those numbers look large, but as a percentage of our overall appropriation, they're not a huge percentage of our appropriation.
Thank you.
The next issue that's listed on page 6 actually relates to what you just discussed about hiring, which is about lapse. And Councilmember Rice will know that we've talked about this every year for many years. And in large part also because when you think about sometimes when you hear that if you hear from advocates about the need for more staff to do things, oftentimes we actually have the pins, but they are vacant. And sometimes in the past few years, because you'll see that there's often been additional lapse, they are held vacant as opposed to just the turnover. Now, in the current year savings plan, the committee asked and clearly heard that the $1.1 million in additional lapse was really related to these OHR process issues, which we hope will go away as people continue to work with the system. And so DHHS is not holding positions, it's just a function of how long it's taking. So the lapse is actually $7.69 million, which it is a large department, it has a lot of turnover. If it stays at $7.69 million for the whole year, that would be frankly like a reduction in lapse from the actuals of the past few years. And so I'm recommending approval, but I think that what we want to do is that we want to see what lapse really is if the department is able during the course of a year to really just fill positions as they become vacant and get filled during the normal process, because I think it's been frankly like so long since we've had that ability to do something like that. It's really kind of unclear what normal lapse would be in the department. So I'm not recommending a change. It's just that they do have a very large number for lapse throughout the department. And I think the key thing here is that they're not holding positions. They're working things through. They're released, and they're looking to be filled. The next issue is the percentage increase for nonprofit contracts. So each year, the council considers whether to provide a percentage increase to eligible contracts with nonprofits and certain other human services providers to offset some of the increased cost of doing business. For FY19, the council approved $979,000 for a 2% increase for eligible contracts. I've provided for you in the packet the actual budget provision so that you can see there is a criteria. It's not for every contract. For example, even for a nonprofit contract, if it's the first year of a contract, since we are making an assumption that in the first year you're getting the cost that you expected, it's not eligible for that increase. But generally speaking, it's the nonprofit contracts in the Department of Health and Human Services that are either funded in the Department of Health and Human Services or charged to the Housing Initiative Fund related to homelessness programs. And so those have been the eligible contracts over the years. The nonprofit Montgomery, as well as several other nonprofits, have asked for a 3% increase for fiscal '20. And the estimated cost of 1% is about $450,000 using the same criteria. The question that has come up in past years and is a question for the committee today is whether the committee would like to look at some of the contracts that actually are in other departments. As we've grown human services programs, other departments now administer them, and so, for example, you might have one nonprofit organization doing youth service programs. They might get the increase if it's in HHS. They might not get the increase if it's in recreation. Well, they wouldn't get the increase right now if it's in recreation. So if there's an interest in understanding what that number would be, what the delta would look like, and if the committee's interested in that, we can bring it back. For now, what I've recommended is putting 2 increments of $450,000 and then 2 increments of $225,000 on the rec list, so you have increments to adjust back and forth that would get you up to 3%.
Just a couple of comments. First, I want to acknowledge what a great job HHS does with the contract monitoring. It's a very difficult process, and I know we've been adding many contracts over the last 14 years and really haven't added a lot of administrative capacity to address that. And I also know Recreation and some of our other sister county agencies are also heavily involved in this effort. I do very much support the staff recommendation here on the increase in administrative costs as proposed by nonprofit Montgomery. Our nonprofit organizations are obviously a vital and critical component to our service delivery across the county, and I have met with many of them individually, and understandably, all of them are requesting some level of additional funds for either enhanced programming or enhanced administrative support. So I really appreciate systemic approaches to addressing those fiscal challenges. And so, and I do very much also agree that I'd like to explore what it would cost to the other contracts that are beyond HHS as well. I don't know if my colleagues have anything they want to add. Councilmember Rice.
Yeah, I just want to agree. I mean, look, we've been doing this continuously for a number of years. We understand the challenges that are facing our nonprofit providers as we continue to provide inflationary increases for other entities of government, it just makes sense for us to do the same thing when it comes to these nonprofits. So I'm going to stick with what we've been doing all along. There's no reason to change now. It's just kind of frustrating. Again, I will just continue to say this because I feel that it needs to be said. You know, we have a county executive who sat here on this side, who voted and supported these kinds of things, who continues to send us a budget that then doesn't have them. And when it comes to a lot of these services that are provided for our most vulnerable, I'm just oftentimes confused because, again, these are things that we know over and over again continue to make Montgomery County the place that it is, a place that continues to support folks who need that assistance and continue to support those who are rolling up their sleeves and providing that assistance and then going out into the public and asking private, whether it's funders or different sorts of philanthropic entities to contribute to make these kinds of things happen. And so from that perspective, I think this is a no-brainer for us. I know that it will be difficult because we don't have as much room on our reconciliation list as we have had in other years, but I think this is something that has to be done. So I would definitely support staff's recommendation.
Councilmember Glass.
I want to second everything that my colleague said, and we were in this room on Tuesday talking about adequate compensation for our workforce, and quite frankly, the nonprofit community that fulfills so much of this work is our workforce. They might not be merit or non-merit employees, and their paychecks might not come directly from Montgomery County, but the work that they do is vitally important to every single resident here, and I think it is important to take a look at their salaries and the work that they do and compensate them appropriately. A question for you, though, Ms. McMillan. Mm-hmm. When was the last time that this type of, if we want to call it a COLA, right? I mean, that's essentially what we're talking about, was done for other agencies, other nonprofits that are not within HHS, as we're...
It has not. The policy had, so the one change that was made, so it has always been related to contracts that are in the Department of Health and Human Services. When funding for programs that are administered by the Department of Health and Human Services around homelessness, when the funding for that was moved into the Housing Initiative Fund and the costs are charged to the Housing Initiative Fund, then those contracts became eligible for that. But those are the only contracts are ones that have programs that are administered by HHS, and the exception is they may be charged to the Housing Initiative Fund because they're with homelessness. So it's never been a policy to go outside of the department.
And so just so I understand what was asked, Mr. Chair, did you ask council staff to look into such COLAs for other departments, other agencies, nonprofits in this?
No, I was specifically focused on the council staff recommendation to look at the corresponding 3% increase for contracts that were not in HHS's department.
Then yes,
Yeah.
we're saying the same thing.
Yeah.
Because to Ms. McMillan's point, you had said, a youth development nonprofit in the rec department isn't subject to this, and I can speak firsthand to say a youth development nonprofit that was in the Department of Technology Services over a 4-year period never received such a COLA. Oh, wow, yes. So thank you for this, and I support the recommendation.
Right. I will say the bulk of these contracts is in the Department of Health and Human Services, but we would need to just sort of scrub in the other departments and see what might be eligible. And I can bring that back to the committee members, and then you can consider that.
Just to put in a plug while we're here for 1 second, I know that the county executive is considering 2-year contracting or biannual budget, a budget that would occur every other year. I think with regards to nonprofit contracts, that makes a lot of sense because understandably there's great anxiousness and anxiety every year to have to apply, and so many nonprofits also understandably want to be in the base budget, which is sort of the utopia, but even that has its challenges. I think multi-year contracting moving forward will help address and alleviate some of the administrative burden that nonprofits are feeling. So separate conversation, more long-term, but just wanted to put that in.
So that actually takes you to the next part of the discussion of contract management. This is an issue that I'm raising with you, which is about the complement of the central contract management team. And so you have in your packet what the current contract is, the number and amount of contracts the department handles. They do have some vacancies right now, but even at times when they haven't had vacancies, the stress on the central contract management team is pretty significant. And I think that one of the things that also prevents them from doing is going back and looking at sort of the base of certain contracts, because it's so difficult just to get the renewals and the amendments and the new contracts and the new grants, out the door, that it's just a very difficult thing. And so I've recommended putting $80,000 on the reconciliation list for a program manager in the central contract management team. And I think that that will help, right? I think it still is a lot of work for a team, even when their complement is full, but I think that it would help.
Ms. Buckland, I used to be on that side of the aisle. I know what it's like to put on tap dancing shoes, but if you could just make some comments regarding that, and then also describe those vacancies and how they may connect to some of those administrative burdens. And maybe what you can do is just focus on the facts in terms of, the amount of workload currently and the challenges that brings, and the potential for errors to be made when you have so much on so few people.
My tap dancing shoes are on. So as far as the vacancies are concerned, offers have been made for all of these. Some of those are conditional offers, so they're not final. I don't necessarily have start dates, but those are pretty far along in the hiring process, which I, as you can well imagine, am very happy about. The overall workload in the contracts arena in HHS is driven by two different things. One is just base budget contracts. The second, which is actually, but the second is in community grants. Both of those have grown over time. Of the two of them, community grants has actually grown much more. The department had somewhere around maybe 70 or so community grants that it oversaw in FY07. We had 235 this year. And I have one fewer staff member in CMT than I did back in '07. So as the conversations have gone on around the community grant reform and changes to that process, as you can well imagine, HHS has been very much involved in those, because it does have a big impact on the workload for us, because all of those obviously translate into contracts. The base budget contracting workload has also increased, not as much, but we've gone from probably around 300 or so contracts to almost 500 now. So there has been an increase in the contracting world for us over time. And, I know that the new administration is very interested in some things that I'm also very interested in, which is looking at results contracting, changing some of the ways in which we scope our contracts to really focus on what outcomes are we really looking for. For my own, and I will editorialize for a moment from my own perspective. The way that we structure some of our contracts now places limitations on our providers and how flexible they are, and how many choices they have available to reach those ends that we're looking for. And so I think that doing some of that work would be really beneficial both to the department and to our partners. That is something that doesn't happen overnight, however. And so all of those things are works in progress on top of what is, that there's a reason we have a central contracts management team in our department, which you don't see really in other departments the way that we have it. So.
Thank you. That was a good summary. I do support that recommendation for all the reasons that have been stated, and also acknowledging that more than just an administrative burden, there is the potential for error when you have so much and so few people trying to hold all of that up, which could have long-term impacts on our ability to carry out services in the first place. These are the kinds of core infrastructure functions you have to have if you're going to have a solid operation. Without objection, then, we support the staff recommendation.
Okay. You've discussed the Minority Health Initiative, so that actually takes you to the middle of page 10, which is the VITA program.
So for fiscal year 20, the executive is recommending $304,423 for the VITA program. It's a decrease of $3,870. The VITA program offers free tax help and free electronic filing for low to moderate income families. It helps individuals access the various different credits that they may be eligible for. So it's one of kind of the big anti-poverty what's the word I want? Things that you can do to help folks in the community. Strategy. The program is funded through both county general funds as well as federal community services block grant funding. And for fiscal year 20, there's an increased amount in personnel costs that's being charged to the CSBG grant. As a result, the program is recommending that a broker that they have full-time, they're recommending that it move to a half-time position. The council receives testimony from the Community Action Board expressing how much that these brokers help in ensuring that services are delivered through VITA and the test center. So as a result, council staff requested information about what is that impact of the half-time position. It's going to be there, I guess, apparently from the heaviest season, tax season, from November to April. But again, we didn't get information back in terms of what was specifically the impact. And so before the committee recommends that budget, council staff recommends hearing from the department again, how will that impact services to folks in the community? And if there is a significant impact, then council staff recommends making up that difference and putting that on the reconciliation list.
So I'll let Betty jump in here in just a moment, but obviously there is sort of a main season and an off season to the tax world. We obviously we've chosen to focus on the on season. That doesn't mean that there isn't anything that happens in the off season, but if we're going to have to make some choices, we're going to focus our resources during the time period when most people have those needs. And so that is the choice that we've made in this case, so that we can retain the program and live within the funding that we have. Betty, if you want to.
Hello, this is Betty Lam with Community Affairs. So one of the strategies of Community Action also is using the existing staff to try to offer year-round tax services. But with the broker, we're able to offer a little bit more, and also in different locations. So with the part-time, we probably will not be able to serve 4 days a week, which will reduce the number of people that we anticipated serving from 756 to 300, and also only offering it in the Rockville area. With a full-time broker, we probably will have the services also at Test Center. And the particular broker that we have is a very well-credentialed tech services person. So So of course, the concern is that we may lose the person if it's not offered as a full-time position. And also then we will probably focus on servicing basic tax return in the off cycle, and not necessarily deal with the more complex and people with I-10. We probably will not be able to serve.
Thank you. So I had the opportunity to visit the VITA program just a couple of weeks ago, right in the heart of tax season, and saw with my own two eyes how powerful the program is and how it relieves so much stress from the county residents that were participating in the program. And I totally understand, again, least worst option, something's got to get cut. But I do think in this case, particularly for those people that are in tax crisis, they sometimes will come during the off season and need assistance year round. And I am also very sensitive to the fact that we're a very diverse county geographically, and so having the program in locations that are closer to where people are is a benefit. And we want people to pay their taxes, because if they're paying their taxes, then they are contributing to our county revenue as a whole, and not then putting themselves in financial crisis. So there's an opportunity cost that comes with this in addition to just the 22,000, in my opinion. So I do support, based on what I visibly saw and the comments now, adding the 22,000 to reconciliation. Councilmember Rice.
Thank you very much, Mr. Chair. Again, another decision, and look, I certainly understand. I mean, we all deal with budgets here, but I mean, in a time in which our tax code has gotten more complicated than it ever has been before, as a person who does our own taxes, who's been intimately involved, who has a wife who has a small business, and seen the amount of labor that I had to put in this year versus other years is just absolutely tremendous. And the simple fact is that a lot of our immigrant community are business owners, small business owners, who need that assistance, who may not have that experience, who may not have been dealing with a lot of the things or have the resources. And so this is incredibly important. It's such a small amount of money that I don't think that we want to go in the direction of providing less service for folks in the context of our over $5 billion budget. You know, at the end of the day, this is something that provides a sense of peace. I will echo what the chair said. People panic with taxes. Taxes is a very daunting thing. The IRS is this entity, this behemoth that's out there that folks see as like, oh my gosh, the only thing I think that folks think that they fear more is being pulled over by a police officer. I mean, there are certain things that people fear, right? Just in general. I'm not talking about the fact of a police officer being a bad person or whatever. It's just that people fear it. I know when I have a police officer behind me and I'm a county council member, I still get nervous. I mean, it's just what happens. I mean, and so in understanding that this can provide a sense of that kind of, okay, I've got this and I feel comfortable with doing it. And I do agree with what Chair Albano said as well, that when we look at them actually doing it, there are a lot of people who fear it so much that then they don't do it. It's not that they're actually trying to dodge or avoid paying their taxes. It's just that they fear doing something wrong. They fear not getting it right. And so therefore they get audited. And so they say, you know what, I'm just not going to do it. And then maybe folks won't pay attention. And the reality is that it's quite amazing. But there are people who not file their taxes for many, many years who don't hear anything. But then folks who do it wrong get audited by the IRS right away immediately. It's kind of interesting. I think the IRS should follow up on that. But whole nother story for a whole nother day. I think that this money is well spent. And I think that for all the reasons that Ms. Lamb talked about as well, look, if I was a full-time person and you said you're going to make mine half-time, I don't think I'd be there. So, and I know that's not the guarantee. I know that, Ms. Buckland, that that's not necessarily the case.
Oh,
Go ahead.
no. I just wanted to make sure it was clear, like, this was not a cut in the general fund. This was a reduction of the grant, right? So that wasn't a cut we had proposed on the general fund side, right?
Oh, okay. All right. But it wasn't,
There's a reduction in the grant is accurate, but there wasn't a proposed fill for
Right.
the gap in service.
right. And again, for $22,120, I mean,
Right.
come on now. So anyway, that's where I am.
Councilmember Glass.
Thank you, Mr. Chair. I associate myself with everything you and Mr. Rice said, and picking up on Councilmember Rice's closing thoughts about people fearing taxes, the process, the audits. Individuals of lower income get audited more often than wealthy individuals, and that's a fact that is oft repeated on April 15th and thereabout, and that's why it's fresh in my mind. And to that end, I have not had the pleasure of visiting this program next year, possibly, depending on when I get my taxes done. But would like to know how one qualifies for it. It says low income, or it says moderate income individuals. And so what are the thresholds? How would a resident go and get their taxes prepared?
I believe it's
Is someone able to? Thank you.
Okay. I'm Sharon.
You can sit right over there.
Okay, thanks.
Right.
Thank you. I'm Sharon Strauss. I'm the Executive Director of the Community Action Agency that has oversight of the VITA partnership and the county's countywide EITC outreach effort. So people are eligible for the Earned Income Tax Credit and through the IRS for the VITA program if they make under $55,000 a year. But in fact, a significant number of the people that we served, I think of the people answering the survey, it's in the circles on the back. Hold on a minute, let me just get to the demographic page. It's, yes, on circle 22, you see the demographics. In fact, of the 1,755 people who responded to our survey, 665 had an average gross income of less than $10,000 a year. And 360 of them had an average gross income between $10,000 and $20,000 a year. So we really do target very low income, people that are served by the department, people who need case management, like through the ARC, to file their taxes. And our community is also very much reflective of the low income population in the county in terms of its diversity. And so I think, does that answer your question?
Well, we're all trying to do quick math here, right? So I need an accountant to do that for me. But but we're talking about, half the individuals at 30% or lower of AMI, area median income.
20% or lower.
20%, yeah. That's incredible. Thank you for that information. And good to know that circle 22, so I'll have the rest of my questions answered by that graph.
Great, thank you.
And then on page 12 is the last issue in the packet for you today, and that is the legal services for low-income county residents in immigration proceedings. And I want to start by saying, and you'll see the table with community grants, the county actually has supported nonprofit organizations in providing legal services for a very long time through the grants process. But this last year was the first year that some new funding was added, specifically around this issue of helping people who were in deportation, immigration proceedings, and also focusing on direct legal representation and screening for direct legal representation, as opposed to many of the nonprofits provide Know Your Rights, they provide referrals to attorneys, but it's a little different set of services. And so for FY19, the council appropriated $370,000 in the Department of Health and Human Services for that purpose. Since this was the first year, HHS was asked to do a solicitation, not a formal solicitation, but asked to sort of put out a solicitation and run it through like a mini grants process, which they did. And then the recommendation was made for the organizations IUTA, HIAS, and KIND, Kids in Need of Defense, to receive that funding, and it came over to the council for approval as non-competitive contracts. So that was the process that was used, but it was a solicitation that was put out there so that we could hear proposals from anyone that wished to apply. The county executive has continued to include the $370,000 in the base budget for the same purpose, but the executive has not, to my understanding, yet made a specific recommendation on how the funds might be awarded. And so I think that that's one of the issues that I've brought to you. However, the terms of the current contracts, which since the contracts first got approved in the late fall and were executed in December of 2018, they're 12-month contracts. They go from December 2018 to December 2019, and they are renewable, so they could be renewed for another year if that was the decision. I did put in the packet a little bit about what's expected of each organization in terms of the number of people that they would serve and how they would serve them. I'm sorry that the table on 13 is a little hard to read, but it shows in the early months of ramp up, right, so December, January, and February. But I would just note at the recent discussion that HHS and Education and Culture had about children fleeing violence and new immigrant families, you did have a representative from Kids in Need of Defense who told you that like they may have to have a waiting list because now that they're kind of ramped up with their staff, the demand is out there for services. So I think that each of these organizations is moving forward in a really good fashion. But again, this is the very early months of the ramp up. And then I did include for you the community grants that are in the budget from the executive. The first column is the executive only recommendation for FY20. There is one new organization, the Ethiopian Community Center, that the executive has recommended. The right-hand column is the total of what the executive recommended in 19 and what the council also added through its grants process. So when you see a difference, that's because that's a total. So in the 20 column, that's not finished yet necessarily. It depends on whether the council, through its process, puts some additional funds into these grant applications if they were not fully funded on the executive side. The executive's FY20 amounts are basically the same as the FY19 executive amounts, with the exception that the Ethiopian Community Center is a new grant. These go through the community grants process, so they're not in front of you today for decision making, but I think in the context of this discussion, it was important that you also see the breadth of what we do in legal services. The thing that is before you today really is the $370,000 that's in the base. I would also just note for you that for a very long time, there's another $54,000 in the base of the HHS budget that is for the Montgomery County Bar Association pro bono program. That is not focused on necessarily on immigration, but that's also been a long-standing support, and it is in the HHS budget. So what I am recommending based on what I've seen to date is first off, I think that the funds ended up distributed to excellent organizations, and I think they're doing good work, and you heard some evidence of that already when you heard from KIND. I actually think it would be good to have the award go for 2 years. And I think that way the organizations could have some consistency, and we could also get really good outcome information and hear what they thought the barriers were. Because right now we only have very limited information in terms of knowing, how many people did they see, who did they see. It was very interesting. I think when KIND talked to you, and it is in their chart, in addition to the youth, they are also helping the adult sponsors. So that was really kind of a part of the potential clients we hadn't really discussed so much in previous discussions. So it would be my recommendation that I think we could continue these for the second year, And then in the next budget, have a policy that we would go back out for solicitation. To do that, I think that the committee would in essence have to seek the executive and the CAO's concurrence, so we could send that over depending on what you want to do, because if you did do that, then you would want to have these 3 organizations on the non-competitive list that you approve as a part of the budget resolution, and those have to come from the chief administrative officer under the procurement rules. So that's the recommendation I have for you.
Thank you, Ms. McMillan. I want to begin by acknowledging the great work of our previous council that dealt with a lot of layers of complexity to this proposal, which I know was frustrating to say the least, but I really do want to credit their leadership in putting forward this initiative. This issue is very personal for me. I've spent most of my professional career advocating and working with immigrant families, and had the opportunity to visit McAllen, Texas just a couple of months ago and see what's happening on the border with my own 2 eyes. And the work session we had recently just underscored that there's another wave of immigrants that are coming as we are talking right now. And all of the immoral practices of this administration to try and separate families and to try and make life a living hell for these families is not working to prevent them from coming here. If anything, it's exasperating the issue. And there's been a record number of families coming over who, in many instances, have very legitimate asylum cases because of the domestic violence or extreme poverty that they are fleeing from the countries that they are coming from. And so I not only support certainly continuing the funding, and I do agree with the recommendation to have 2-year budgeting, and so we'll wait to hear back from the executive branch, depending on how my colleagues feel about that. But I do have a question for Ms. Buckland and Mr. Waters. About a month ago, myself and 4 of my colleagues were at a community meeting hosted by Action in Montgomery, and as usual, they turned out a number of passionate advocates who, I have to say, I'm so feel blessed and fortunate are living in our county. But he did publicly state that he had added, I believe the number was 170,000 or so on top of the 370,000, which is not reflected or we can't see in the operating budget. And my colleagues and I were prepared on our own, even before that announcement was made, to recommend that we actually add some funding, particularly for those asylum seekers. But are you aware of any additional funding that was placed in the budget? Was this a discussion point and maybe didn't make it in the end, or do you have any information about that?
I would need to follow up and get back with the committee on that.
Okay. Thank you. I did commit to that number there, and so I commit to that number now, which would take the 370 up beyond 500,000 to 540, and that is something that I do believe, specifically with regards to those asylum cases, and as we heard from the nonprofit organizations that are providing these critical legal services, as you said, Ms. McMillan, are already experiencing pretty extensive waiting lists. So that's something I'd like to move, but would very much like to hear back from the executive branch if there was some other pot of funding that maybe is in another location that we're not aware of. It would be helpful to know. But I don't. Any comments from my colleagues?
Thank you, Mr.
Councilmember Glass.
Thank you, Mr. Chair. You asked the question I was curious about. I was, if not sitting next to you, I was in the same room as you during the county executive's declaration there, and so appreciate some clarifying regarding that. I don't know if he was taking into account the grants on page 13, incorporated that, but it seems that most of those are existing grants anyway, so it's not new, it's not on top of, and I second the motion to add some funds to the reconciliation list to do what we have to do to make sure every resident of our community remains safe. And hopefully this is not a conversation we need to have in 2 or 3 years when we change the tone and tenor in Washington, change the administration, so that these conversations of protecting our communities don't have to go on ad infinitum. So.
Councilmember Rice.
Well, thank you, and I couldn't agree more with both of you. So I just want to understand how much is actually then we would put on the reconciliation list, Linda?
Sounds like you're saying 170,000?
That was the number that the county executive quoted publicly.
And so, just for the chair, and so are we putting this on in, and then assuming that the county executive is honoring his commitment, and then we'll take it off? Or, well, we have Office of Management and Budget, it's here, right? So, yeah, I mean, is there a commitment from the county executive to honor what he said that he was going to do?
As I mentioned to the chairman of the committee, I would have to follow up on the county executive's comments. I wasn't at a meeting where this was at.
Okay, well, I mean, Linda, maybe we should have a committee letter, as we've done previously some other times, to seek clarification, to formalize. I'm certainly supportive of putting this on the reconciliation list, but certainly if it's something, I just heard from the county executive the other day about commitment for education funding. So, and then I understand a budget supplemental may be coming over, so, or budget amendment, I should say, will be coming over. So in this case, I'm not sure if the same thing may be applicable or not, but it's certainly something where we should seek further clarification to ensure, where the county executive is in this funding mechanism. But I certainly support putting it on the reconciliation list until we get clarification from the county executive.
And without being too prescriptive, is there an interest on the part of the committee that when, if funding is approved, that when the proposals are sought, that responses include how you would serve people who are eligible for seeking asylum?
Yes.
Okay. Okay. So then I'll follow up on that, and maybe we'll send something with the chair. We'll send something over the executive on behalf of what the committee would like to do. For now, we'll track it on the reconciliation list so we don't kind of lose it.
It's a great
right?
idea.
And then we can see what the response is.
Yes.
Okay. And I think that is it for this particular packet. Okay. And the next packet you have is on public health services. I would just note for people, this does not include school health services that HHS reviews jointly with Education and Culture Committee. And so for FY20, there are 14 program areas in public health and a total of $76.7 million. Again, at the beginning of the packet, I've just provided for you an overview table, a summary of what each of the programs is and what the dollars are. And so if there aren't any overview questions, then we could get into the specific changes that are listed in the budget that start on page 4. Okay. And the first one, and I will say there are going to be a few of these where it's just multi-program adjustments, as it is in communicable disease and epidemiology. And so I would recommend approval of that. On page 5 is the tuberculosis program. There are actually 2 changes to this, and neither change is frankly particularly controversial in and of itself. The first is eliminating the funding that was with a long vacant medical doctor position, but they've been providing those services in another way, and so they've reduced that, as well as the multi-program adjustments. But I did provide an excerpt in the packet from the department's report on infectious disease discussing TB in Montgomery County, and Dr. Gales has spoken to you a little bit about this before, but I didn't know if you would want to hear just a bit from him about what the trends are in tuberculosis, as well as sort of the prevalence in Montgomery County compared to some other areas of the state. Yep.
Dr. Gales.
Good afternoon. Always a pleasure to be here with you all. As it relates to tuberculosis, we have seen a little bit of an increase in our incidence over the last several years. The majority of our cases are foreign-born individuals, and this is consistent with at least 2 other jurisdictions within the state of Maryland, Baltimore City and Prince George's County. We have raised this concern with the Secretary of Health, who has heard us and listened and attempted to add to a supplemental budget item at the state level additional funds for the state overall, but in particular the 3 jurisdictions. That particular supplemental was not taken up in the legislative session, and so we, in my last meeting with the Secretary in earlier April, I meet with him again next week. He did mention that the health department is looking at alternative ways to provide that funding absent the supplemental moving forward.
Thank you.
The next program area is the STD HIV prevention and treatment program. There is, and I would just say there are several large grants in this particular program, and so sometimes the way the grants come in during the course of the year, actual to expected, sometimes we see really large swings. In this case, it's actually for a fairly modest swing in what the budget reflects in terms of the grants of $66,430. But again, in the packet, I included 2 things. I have to say the infectious disease report is it's big, but it's a very interesting report because it contains just a tremendous amount of really good information about real public health issues, communicable infectious diseases, about Montgomery County. We haven't really had one of those before, so it's a really great resource. So again, I would let Dr. Gales talk to you a little bit about that. And also, I included a recent email that he did send to you talking about some other efforts and funding from the federal level. So if you wanted to talk about that.
Sure. Just briefly, again, STD rates are on the rise, gonorrhea and chlamydia in particular, and they are disproportionately impacting young persons ages 15 to 24. We've also seen an uptick in syphilis rates, primary and secondary syphilis, and this was a conversation we started last year. As you know, we moved forward and were able to increase access to condoms in the school health and wellness centers across the county, the high school level, and we have continued conversations to look at how we can expand our resources to build a broader network to increase access to screening and treatment provisions in other areas within the county, particularly after hours. Those conversations continue, and one of the efforts that we've looked at and we're continuing to explore is utilizing those health and wellness centers after hours to provide services. And I've had at least one really in-depth conversation with the current director of the Department of Recreation to talk about how we can partner together utilizing their after-hours programs, particularly with youth and young adults, to raise awareness about STDs within the county and look at how we can increase access to screening and treatment provisions. Now, this takes one added importance with, as I said, the communication that I sent to you all as the Board of Health on last week. We have been identified as, with the President's new push to continue the efforts that have been longstanding to end the epidemic. We have been identified as one of the top 48 counties out of over 3,000 counties in the country that contributes collectively, plus DC and Puerto Rico, contribute 50% of the new HIV cases. And CDC and HHS has prioritized providing additional funding sources to those jurisdictions to be able to build capacity around either continuing long-standing ending the epidemic programs or creating new infrastructure. Given our history, we're going to be in that latter part in terms of creating more infrastructure around and enhanced prevention. Again, continued access to screening and treatment provisions, as well as continuing to support our robust program that we already have in terms of offering support services for persons living with HIV within the county. We do have to do some, and I mention that because STD services goes hand in hand with HIV, particularly for young people, because even though the incidence and prevalence of HIV cases in young persons 15 to 19, it does start to increase between 19 and 24, is really, really small, pretty much non-existent in the county. Those gonorrhea and chlamydia rates, cases now that are 15 to 19, excuse me, move on to become our, if we don't intervene early, move on to become our HIV positive cases later. So building a network for HIV prevention is contingent upon having a solid infrastructure that provides adequate access to STD prevention as well as access to screening and treatment.
Thank you. Got a couple of lights. Councilmember Glass.
Thank you. In the packet, I'm alarmed to see that the county is third in the state behind Prince George's and Baltimore City in terms of HIV rate and infection. And that's clearly not good. And the statistics that you've cited or alluded to regarding our school-age population, I remember seeing heat maps with the clusters and was absolutely alarmed, horrified, quite frankly, by the areas in the county that were having higher experiences of infection. But my question as it relates to this, so the 66,430, you've mentioned, Dr. Gales, the partnerships and the collaborations regarding tackling this, but what is the goal here, or how do you see this particular item being used? It's grants, and who will those go to?
Sure. So as Linda mentioned, the network of grant funding for STDs and HIV is pretty extensive, and so there's numerous grants. The majority of them are funded through the CDC and to the states, and then they're parsed out from there. And so what those funds support are one, surveillance and data capacity. It supports workforce development, particularly as it relates to service providers. So one of the great things, one of the successes this past year is we were able to recruit an additional nurse practitioner to our Dennis Avenue practice, which then increases our capacity to be able to move some folks occasionally to rotate up in the northern part of the county. For example, at the Germantown Health Center, to be able to provide screening services there, screening and treatment services there. And that addresses or helps to start address one of the things that you mentioned is a geographic gap in terms of services. Because what's interesting is in the northern part of the county, we know that a large portion of the Latino population is moving to that area. And the one group that we have seen an increase across the region in terms of new HIV cases is in young Latino men who have sex with men. And they're moving from the city or around the city to the northern part of the county. And I can attest to that because during my time in DC, when we opened up our PrEP program there, we had a large number of folks in that demographic group driving from Germantown to DC to get PrEP and to get follow-up services. Since we have implemented our PrEP program here over a year ago, we've been able to recruit a large portion of those individuals now that we have a viable option for folks and they don't have to go all the way down to the city. So funds go to increasing the workforce component. In addition to the service providers, it also allows us to hire more public health associates and analysts who do a large portion of the prevention work. They do the prevention and education. They do the navigation of services. So for example, We're looking to enhance our ability to, if an individual comes to the STI clinic who tests positive for a particular infection, we can navigate them to conversations about PrEP and HIV prevention in other areas. They also do disease investigation, which means that when we have folks who come in and test positive for respective diseases, they can do follow-up with folks in their networks to make sure that they are getting screened and tested appropriately. Those funds also go to helping enhance this education outreach efforts in general. So whatever the venue is, whether it's in a school health center or community center, there are still funds there that are able to help support those efforts and larger things.
And that's good to know. I just wanted to make sure that it wasn't towards more simplistic, important but simplistic purposes of, having more condoms at centers or in wellness centers or anything like that. But it's more thoughtful, deliberate, and extensive, and I appreciate the response. Thank you.
The other thing to keep in mind as far as grant funding in this area is that there are a whole variety of grants that fund this, and the mix of what gets funded under which grant, how much, is not only does it change year to year, it often changes within years. So it's a little bit of a moving target. So I would caution to not read too much into some of those movements because it's just really common.
And I would just follow up because it's really in public health services and behavioral health and crisis services, there are these large grants. And the way the budget is set up in that you are reading is about, looking at this original approved to the recommendation. And sometimes there's really not an impact. Sometimes there is, but it's just a function of sort of how they landed grant to grant in a current place. And so this and behavioral health are the two places where you can see kind of what look like might be big changes sometimes, but aren't. Sometimes they are. And so you sort of have to tease it out a little bit.
Councilmember Rice.
So, Mr. Chair, I want to apologize. I actually meant to ask one of the questions with one of our previous things, so I'm going to do that if you grant me just a moment. Measles. When we've talked about and we've seen this epidemic that now is crossing across the United States, that's as in large numbers in New York. So very, very close to us on the eastern seaboard when it comes to some of the rampant numbers that we're seeing. But is there any concern from you as our public health officer about our susceptibility to measles outbreak here? And if so, do we need to start ramping up some of our efforts to ensure that, at least from a public promotion standpoint of understanding about vaccinations, those kinds of things, do we need to do that at this point? Are we okay? And then I have a question about STD, HIV after that.
Okay. Well, we actually already are doing some efforts around measles, and part of it is that means we've done our job well if you haven't had to hear about it. So that's a good thing, and kudos to the staff and the team for executing that. So yes, it is of utmost importance. We have been in contact with the state. As you know, there have been 4 cases in Maryland so far. 3 of them have been in the greater Baltimore area, and then 1 in Pikesville. And the first 2 were actually the second case was a household contact of the first case. And so since that first case was discovered, we have been in touch with the state and with the Baltimore City Health Department to discuss what other jurisdictions needed to do. Now, in Baltimore's case, they were able to mobilize, and they found that the cases were, the index case was exposed in New York, in the Brooklyn area, in the Orthodox Jewish community, and given the high amount of travel between the 2 communities, there was an extensive effort within that community to mobilize and provide vaccines for the kids are covered. It's a lot of the adults who aren't sure of their status. And so they completed that process, and the state made the decision that given that it has been confined really to one community, to prioritize resources being made sure that they're available within the Baltimore area. Now, secondly from that, we did actually on Monday working with a local rabbi. And forgive me, I'm blanking on his name, but he works in the governor's office. Rabbi Singer, who contacted the state, and we were contacted, and we facilitated a vaccine clinic at one of the local synagogues, and were able to provide immunizations working with the state. I want to say it's 276 individuals. And we also worked very closely with our partners at Holy Cross, who provided some staff to help make sure that the vaccines were delivered. And Homeland Security as well, and emergency preparedness. So the short and long answer is yes, it's of concern. We are getting daily updates, and in fact, I have a call with all of the health officers have a call with the state tomorrow to discuss the next step in the plan. And once we get further guidance from the state, then we'll be able to scale up as needed on a local level. But right now, we're in a holding position.
Fantastic. Well, that just shows how great our county health department is and the great things that we're doing. Now, with regards to STD, HIV, one of the things, Dr. Gales, and you've heard me say this before, is the biggest disservice that we've had when it comes to STD communication has been that when folks all of a sudden weren't fearful of HIV and AIDS any longer, then protection went down in terms of usage. When folks thought, okay, there's no longer this big epidemic, I can go and do whatever I want. And so that's one of the reasons why I think, and anecdotally we can see it, that there's this rise in STDs because folks aren't fearful and thinking that HIV and AIDS are the things that they were before that struck fear in so many people that said, I need to have protected sex. And so from that perspective, I'm just curious as to, with regards to these grant funds, of course, obviously with contraception, but I'm assuming there would be a huge marketing push, social media, those kinds of things, to be able to educate people about the continued risks that are still out there and what we need to continue to do to inform people of how it's still dangerous to have unprotected sex.
Sure. So with any grant funds we receive, whether it's through the HIV, to borrow you all's term, the HIV tranche or the STD tranches, education is of the utmost importance. And I was very excited to hear Linda's reference to our infectious disease report, because that means people are reading it and it's serving its ideal purpose. Is we want to make sure that folks are empowered with the right information so that they can make healthy choices on an individual level as well as on a collective population level. So the short answer is yes, we will continue to provide that education, and certainly with the ending the epidemic plan that we are tasked with putting together. The first part of that is letting people know that, hey, yeah, we're in the top 48. We may be at the bottom, but we're in the top 48, and educate folks on the exact numbers and what that means. So, for example, when we talk about comparing ourselves against other jurisdictions, last year, the incidence of HIV cases in the county was 164 cases. So what does that mean? You're like 164 out of 1.2 million people? The rate seems low, but then you start looking at, I believe Baltimore City had 260 cases, Prince George's had 350 cases, and the District of Columbia had, I think, 368, somewhere around there. And great in comparison to past years, those numbers are much better. You're not seeing thousands of cases each year, but it shows that in spite of our technological advances, our medicinal advances, we still have a tremendous amount of work to do. So we have to educate not only just on the perspective of here are the numbers, we have to educate people about prevention options, whether it's biomedical prevention in the form of PrEP medication. There are new alternatives coming out beyond just taking a pill. There's injectable options that are still in the pipeline. We need to educate people about the risk of unprotected sex, STIs, and how they may predispose you for HIV. But then there are other areas that we need to think about, particularly as it relates to things such as undetectable equals untransmittable. And so educating people about it's not just for those who are HIV negative being prevented, but for individuals who are living with HIV, doing what we can to provide the resources so that they achieve undetectable drug levels. Because quite frankly, from a clinical perspective, that is the biggest impact. I think that has the biggest impact in terms of preventing new cases. So yes, extensive PR efforts and marketing campaigns, but across the spectrum, not just sex can get you in trouble. It's, if you are living with HIV, let's talk about being undetectable and educating the full public about the full spectrum of things.
And I'd just like to follow that Councilmember Glass in terms of his assessment of where those hotspots are, the places where we saw where the higher incidents are certainly ones in which we'll, of course, I assume, be targeting those particular areas. And so as chair of the Education and Culture Committee, who represents a large cohort of these young individuals, please continue to work with us and let us know how we can continue to work with our school system partners, Department of Recreation, and others to ensure that we're reaching all of those folks in those particular areas, especially. We want to make sure that countywide we're sending this message, but especially in those areas where we're seeing the higher incidents, we need to work with our faith partners, our Office of Community Partnerships, everybody that's involved and engaged to make sure that they all understand how important this is and how we need to drill down on this area. And so I really just want to appreciate your work on this and any other creative recommendations you have in which we can do to ensure that we're continuing to turn the tide, I think would be welcomed here on the dais. So thank you.
Thank you. So without objection, we approve as recommended.
Okay. Public health emergency preparedness and response. Again, these are just multi-program adjustments for approval. Healthcare and group residential services. Again, just multi-program adjustments for approval. I did just include a little information for you because I noticed in the performance measures, it talks about nursing homes and harm deficiencies. And so there is a little bit of information on what the county's responsibilities are related to nursing homes. As you know, public health services has a really wide range of responsibilities, but this is kind of a critical one. So it just describes for you what they do when there's immediate jeopardy versus what they do when there are sort of other harm conditions. But there's no recommendations specifically around that. Okay. The next is cancer and tobacco prevention, and that also has multi-program adjustments. The Women's Health Services has adjustments to several grants. I did include the information for you that the FY20 award for the breast and cervical cancer grant is about $460,000, and the early detection and control award is for about $441,000. So there's about $900,000 still in grants from those sources. And then there are multi-program adjustments.
Ms. McMillan, I'm going to stop you there for a second on cancer and tobacco prevention. We've recently received briefings on vaping and its growing prevalence as young as students in middle school, and we've had several incidents within MCPS just this year alone that are alarming. And it's growing so fast as an industry, parents are being caught off guard, children are ordering them online, so they're not getting them from those traditional retail sites, and they're having them sent to neighbors' homes who they know are out of the area or at work, and then picking them up. It was a huge alarm bell from our Montgomery County Public Schools, and Dr. Gales, I really want to commend you. You held a meeting within the first month of me becoming a council member that I think will require a lot of follow-up in the very near future. I have spoken to my colleague, Councilmember Rice, about possibly doing a joint education and HHS committee session, which is going to be coming up. And so while I want to wait until after we have this conversation to find out what can and should be done from a prevention standpoint, this will likely require resources Not prepared to recommend anything on the reconciliation list until we have that conversation, but acknowledge we need to have that conversation. And given the urgency, there's every bit the possibility that we shouldn't be bound by the budget structure in dealing with this and may possibly need a supplemental at some point during the new year so that we're fully prepared for the upcoming school year. My colleague, Councilmember Rice, has his light on as well.
Well, thank you, Mr. Chair, for your partnership and your advocacy on this issue. And Dr. Gales, thank you for your leadership in really highlighting this and spotlighting to the community just how much of a challenge this is going to be for us. Because I think that, again, as we heard the chair say, a lot of our parents and general adults have no idea what we're talking about. They've heard of juuling and they think of typical vaping. They think of the typical larger mechanism that's got a spout that comes out of it and, looks like a, some sort of hybrid machine versus a simple, thumb drive that actually acts the same sort of way and is quite dangerous. When we understand the pods that it can be refilled with, that contain everything from questionable chemicals to actual cannabinoid oils. And I've seen it in my travels this past spring break to University of California, Davis and to University of Illinois. They're prevalent. They're prevalent on college campuses just like they are in our high schools. And so this is something that really is a public health concern at this point. And I think that it's more than just about the vaping mechanism itself and what it can physically do to your body, but it also does, to me, strike the urgency of K2 Spice and what other chemicals are being put in that folks don't know and just assume are going to be some sort of nicotine delivery system, when in fact it could be a multitude of chemicals that are there. And without the checks and balances, it's really concerning to me about how many more of these incidents are going to have before it actually results in someone actually dying versus just being taken to a hospital or passing out in a hallway. And so I think that we need to take drastic measures at this point. This is not something, when I look at smoking cessation devices that I've supported for a very long time, both at the state level when I was there and here at the local level, this is one that I think provides exactly the opposite. It's a way in which folks can get hooked on nicotine and then carry them to other sorts of nicotine delivery, including going back to tobacco. And I quite honestly think that that may have been the intention, although I don't have proof of that. But, it's just one in which it's concerning to me. When you look at the backers of these particular products, you have to question and wonder what the true intent was. And so how it's being marketed, all of those kinds of things strike me as something that we need to be aggressive as possible. I know that you continue to comb through ideas and figure out which ones will make sense for us, but I just want to say for the record that I stand very supportive of doing everything we can to ensure that we are limiting this and limiting exposure of this to our community, because what people don't know, and Dr. Gales, if you could just very briefly, I know we're going to go into this, but just very briefly just say about what the concerns beyond the actual product itself in terms of nicotine and maybe other chemicals, but what the actual vaping mechanism does to the physiology of the lungs and the body, so that the millions that are watching at home, as Councilmember Jawando likes to say, can understand about why we're so concerned about this product.
Sure. Well, from as a pediatrician and given the interest in young folk and adolescents, is the big reason we're concerned about adolescents use. There's several reasons we're concerned they're using vaping mechanisms. Early exposure to nicotine can have significant impact on the development, the maturation of the prefrontal cortex of folks. Even though we treat 18-year-olds as adults, their brains are still forming and still maturing. And particularly between the 18 and 21-year-old time period, you need your prefrontal cortex for higher level executive functioning. That's your cognitive center. It's your emotional judgment center. And any exposure to nicotine can impair certain receptors within those areas that can stymie the growth and maturation of that area. So that's why we, from a clinical standpoint, are more nervous about your exposure to nicotine, even though, yes, it causes issues in the lungs, but for adolescents, it's really about brain development. For young people, we know that early initiation or exposure to nicotine also increases withdrawal symptoms to nicotine, even if it's a small amount. There's increased withdrawal experience. As well as we know that early initiation to nicotine also predisposes young persons to using more significant substances. And the big concern with vaping is, as you alluded to, is that they're liquids. We don't know what's in the liquids. And you mentioned that there were episodes of students in school settings where they were required naloxone to be administered. I can attest to you, and actually gave a grand rounds presentation at MedStar up in Olney today, and one of the questions I asked, I said, any of the clinicians in here worried about if someone's vaping in purely nicotine, you're going to ever need to have naloxone administered? And they're like, of course not. So that tells us right there that kids are already utilizing other substances in the vaping devices, and it's clear liquid. We don't know what's in it. And when you mention K2 and spice and those things like that, we worry, especially given our location to other jurisdictions. We know that fentanyl and other things have been introduced into supply, so that increases our risk of having a catastrophic event. We've had, if students have to have naloxone administered, to me that is a sentinel event right there and potential catastrophic event. So those are the risks and those are the concerns. And certainly anytime you are having black markets or trying to get stuff outside of the legal spectrum, there's always that concern too.
So I think where we are is on page 8 at the Chief of Public Health. The first issue here is a $14,000 item for Health Department accreditation fee. There is some information on the background of Public Health Accreditation Board. The department is going through accreditation right now.
Yes, we had our site visit Tuesday and yesterday. So, and there is the report comes out, I think, in another 8 weeks. And we'll know the decision.
So this is just to account for the fees that are associated with accreditation. And then there are multi-program adjustments. And then in your packet, I did include a letter that the Commission on Health sent to the HHS committee that both highlighted the recent really good reports on zip code ranking and infectious disease, but discussed the staffing level of epidemiology statistician staff in public health services in Montgomery County compared to the standards for other jurisdictions. So I wanted to make sure that you were aware of their concern about that. I'm hesitant at the moment. I'd like you to hear from Dr. Gales. I'm hesitant at the moment on recommending any additional staff for 2 reasons. One, I think this is another thing that when a new director comes would be part of a conversation. I would just emphasize epidemiology and the ability to analyze statistics is going to be really critical to any equity effort, but I think we also don't know yet what the executive's plans are for whether he plans to have that capacity in any, centralized location or how it would fit in with other issues around equity. So, so that's really the reason for kind of waiting to talk about this more, but I think you see right from the zip code report like how important it is to have the capacity for good data if you're really going to start to look at the equity issues that you want to in public health and other areas. So I don't know if Dr. Gales had comments or Vicki had comments.
So I know this is not the forum to ask for additional resources and so forth, so what?
Actually, it is.
Yeah. I'll say this. I think that, I agree with everything that Linda mentioned. It does beg the conversation, and I know that I have spoken with the chairman about this before in terms of building more of a modern surveillance and data infrastructure. that is not only in comparison to our peers, but is up to speed in terms of being able to perform the type of statistical analysis and data gathering that we need to do this higher lift and higher reliance of data to help drive our strategic principles. And, you know, I would welcome further conversation after this, once we do have a new director in place, to be able to provide more insights on that.
And I will note that the department has already, I mean, obviously, the zip code report happened with what we've got. And the department has been making investments in other areas across the board. The epidemiology staff doesn't exist in a vacuum. It sits within a larger data analysis capability within the department. And that's certainly accessible from all of our service areas, including public health. So I would agree with Linda's recommendation. You know, this is the kind of discussion that a new director needs to have. That's not a discussion for right now.
So I totally concur, and let me just say, Ms. Buckland, I so appreciate the work you've done holding down the fort during some especially challenging times. Does the executive branch have any updates that you can share with us on where we are with the search?
I'm certainly aware that the search is ongoing and is, I think, in a relatively advanced state. I do not have a timeline. I am not privy to a timeline. But I do know that there are candidates under serious consideration. So certainly my anticipation is that that's something that we would have sooner rather than later. But I don't know what the timeline is.
Gotcha. Thank you.
Is there anything the chair wants to share?
The next area is actually a new program. It's a relatively small amount of money, and it's called Health Promotion and Prevention. And it discusses what they want to do. And Dr. Gales has talked a lot about health promotion and the need, and you all have just talked about the need for health promotion. But I did just want to also note for you that when we had the joint discussion about children fleeing violence, there was an issue that actually came up because we talked about care for kids and the health needs of the immigrants that are coming to our area, about how to get how to create a linguistic and culturally diverse group of health promoters, and to make sure that our health promotion is coordinated throughout the different parts of county government. So I just did want to mention that it was interesting that this is here, and then that this recently came up in your other discussions as well.
Councilmember Rice.
Yeah, so it's one in which it ties into my overall motion before to increase minority health initiatives and to really start to get and to drill down on our ever-growing diverse population, but then also in terms of outreach. And that's one of the things that I think is incredibly strong with our minority health initiatives, is that what we see in our Office of Community Partnerships, which is very interesting, we have individual entities. So we have one for our Asian American population, one for our African American population, we have one for our faith-based population, because we know that people are strategically placed in ways in which, and they know how to best reach their individual cohorts. And so from that perspective, I think that once we have a new director on board, I'd like to really have a conversation with them about these initiatives as a whole and how best we can continue to promote health to some of our underserved and underreached populations. Keep in mind that a lot of times there are services that we're providing that folks just don't know are out there and can avail themselves of. And so it's both. You know, we always talk only about the fact of underserved, but we never talk about the underreached. And so we really have to, I think, do a better job, which is why I put that motion forward for the $50,000, because helping to reach those populations and tell them about the services that are out there and make sure that they're availing themselves of those services is also incredibly important. We have a great nonprofit community here in Montgomery County who does a lot. I mean, from our faith-based communities to our just standard nonprofits, and they're all out there working, and a lot of people have no idea what they do each and every day. And so from that perspective, being able to coordinate some of that makes complete sense. And I know, Dr. Gales, you've expressed some interest around doing some of that and helping to coordinate and bring some of those things together. I think there's value in that. I also think there's value in making sure that we also boost our individual organizations that continue to focus on each of our individual underserved communities because that's important as well. And so I'm not going to make any recommendations at this point. I think that this is something that I want to watch, but I'm very anxious to see what our new director may have to say about this particular vision and what we're looking at in terms of outreach to our greater communities as a whole. So thank you, Mr. Chair.
The next in community health services reflects the new Babies Born Healthy grant, and actually Dr. Gales has spoken to you about that before, and so I would say just approve that as recommended, and there are multi-program adjustments. And then you move into health care for the uninsured. The first program within health care for the uninsured is Care for Kids. Care for Kids, as you know, provides both medical and dental services to children who aren't eligible for other health or dental programs. And the interesting thing about it is provided 3 ways: through a network of private providers, through the school-based health centers, and graciously and generously through Kaiser Permanente at no cost for the children that are covered by Kaiser. So you had a discussion of this recently, and you heard about the trends of international student enrollments and also the unaccompanied minors through Office of Refugee Resettlement. And so included in the packet is information about enrolled children and visits. The executive has not recommended any changes to the funding for Care for Kids for FY20. And on page 12 is some budgetary information. I would say that and I've referred to these folks as the group, so you've all, I think, met with, they sometimes call themselves the Troika, but Montgomery Cares Advisory Board and the Healthcare Leadership and Primary Care Coalition. So they have made some recommendations, and they have been very specifically focused on the need to raise the rates for the private providers so that they can reach 85% of the Medicaid rate. They have not had a rate increase since 2008, and since so many children are cared for through the private providers, there is concern on their part that we do something to look at those rates. And I would also say that very graciously they gave me some prioritization. Of course, they have advocated for their full request, but they know that the business of the council sometimes means we have to divide things, and so I'm very appreciative of their advice to me. So in this item, they recommend that, let's see, they recommend that you can have 59,000, which would be the first phase, and I'm recommending that that is on the reconciliation list. They also recommend adding 58,000 as a tier 2 to get to their full request. I'm not recommending that for fiscal reasons, but the committee clearly can put it on. So they're 117 they are recommending in a tier 1 and tier 2 recommendation. I would say, before we talk a little bit about the quality assurance one, that I'm also recommending placing $100,000 on the reconciliation list in the medical provider category for what I think is going to be an increased need for medical and dental services. Actually, the advocacy piece started being put together several months ago, and I think that what we heard is that this trend, this big increase, is fairly recent, but that certainly MCPS believes and others believe that we're going to see it for a while. And the children, when they come first, right, so the new children that come in generally have, a lot of them have dental needs. And so this would be just a general resource increase for next year. And that is my recommendation. And again, I think this has come up probably more recently than when we started discussing this at the Montgomery Cares Advisory Board. And then the other recommendation they have is $70,000, and this is actually, they would like to create quality frameworks around all the programs in healthcare for the uninsured. Montgomery Cares actually has a pretty robust set of performance measures and a way to look at patient outcomes to make health improvements. And so they would like to start doing that in Care for Kids. And they've asked for $70,000, but they have also indicated that it could be done in increments of $40,000 and $30,000 in implementing. So I would recommend placing both of those on the reconciliation list.
I very much concur with that staff recommendation. Did have the opportunity. I've been familiar with their work for quite some time and have always been very impressed by the collaboration to really strengthen our safety net. And I think that kind of collaboration, just as I mentioned, the support for the nonprofit Montgomery 3% increase should be acknowledged and rewarded, frankly. And also, I really appreciate Ms. McMillan, based on the conversation we did have a couple of weeks ago, the foresight and your wisdom in anticipating challenges ahead and putting us in a better position to address those challenges. So I completely concur with the staff recommendation. Councilmember Rice.
Yeah, Mr. Chair, I do as well. And Linda, I just want to understand, so 2,935 visits as of February. And last year we had 4,600 visits total.
Yes.
Okay. I mean that in itself says that we're going to have a surge this year. There's no question. I know that typically a lot of people try and do their visits at the beginning of the year. I know how that works, but from a realistic perspective, there's just so many things that are going on. I think this is smart for us to do so. All right. Thank you.
The next program is Montgomery Cares. The executive is recommending funding of $11.6 million for Montgomery Cares, and of course this is the program that provides access to medical services to low-income uninsured adults, county residents. It is a net reduction, but I would just say that the bulk of that reduction is in DHHS administrative costs, so the executive has sustained the funding in all the, primary care categories, pharmacy, those things. So I wouldn't want to give the impression that the reduction is actually an impact in service. The group has requested several things. They've requested adding 2,000 encounters to keep up with the projected FY19 participation. They would put all of that in a Tier 1 priority. Increasing the encounter reimbursement rate by $4, and they've split that in a Tier 1 and Tier 2, which is basically $3 and $1. Essential adult immunizations, the $230,000, which this is based on funding that would be focused on providing the clinics the ability to have two vaccinations for patients. One would be pneumococcal pneumonia, and the other is tetanus, diphtheria, and pertussis. And then also increasing specialty care funding. I am recommending putting the $161,000 on the reconciliation list for the primary care encounters, and that would, I just wanted to say that's like, in council staff view, that's the highest priority, is to make sure we have the primary care visits funded. I would place 4 increments of $77,975 on the reconciliation list so that you would have dollar increments to get to the $4 to look at later to see how that might fit with how you're looking at other increases for nonprofit partners. I would place $100,000 and $130,000 in increments as recommended for immunization, and also the $55,000 and $70,000 for the specialty care in the increments that they recommended. And I would just say for you, in terms of the immunizations, the Primary Care Coalition did a couple years ago get a grant that allowed the clinics to do some immunizations, and they saw an increase of from 5% to 25%. So I think from a public health perspective, immunizations are a pretty cost-effective way of doing things. But to date, there hasn't been, we have pharmacy funding, but there hasn't been funding for immunizations. So,
Councilmember Rice.
And so I'm assuming this would include MMR immunizations, or no? Would that not be included in this immunization for adults if we had an outbreak or wanted to get ahead of that curve?
Well, my understanding, the recommendation that came from the community was for those two that Linda mentioned. However, if it were funded, if funding weren't tied to specific immunizations, we would have flexibility to be able to discuss which vaccines would be
it's the
supported
funding,
within there, so.
yeah, and the funding isn't like, it isn't tied, but the clinic directors in the Montgomery Cares 2.0 process, one of the things they looked at was the list of required
Right.
immunizations, and these were the two that they found most critical at that time, right?
So
That's
what
the reason why I would
yeah,
suggest that we
yeah.
give the flexibility to make sure that, I mean, with the example that you just gave, it would make
And so-
sense.
And what I
And-
would say is we would look at utilization trends. We would look at the population to make sure that we have access to the age-appropriate vaccines. I know they've done some of that analysis already, but we would use the data to determine, how it would be allotted.
Okay. The next item is maternity partnership. The executive is recommending a reduction of $102,000 to the maternity partnership, which is based on the historical use and spending. And as of March, 960 women had enrolled during FY19, and that was a decline of 8% from the same time period for FY18. So I would just say, with no change to the program, that would be an appropriate reduction. What the group has asked is that maternity partnership is the one program that has a different eligibility threshold related to federal poverty level, and it's set at 185% of federal poverty level, where the other programs are up to 250% of federal poverty level. And so they are asking for $62,800 for the expected increase in participation that would come if you increased the eligibility income, because more women would be able to participate. And for some of the clinics, they've said it can be a little problematic if they have a woman who is a regular patient of the clinic, and then they can't refer to maternity partnership because the income falls in between, that 185 and 250. This is not limited to Montgomery Cares patients by any means, but it would make it consistent as an eligibility requirement. And so I would just recommend putting that on the reconciliation list. Okay. And then the next program is dental. And there are just multi-program adjustments on this. Dr. Gales maybe could give you an update on where we are with the dental director. And then also I would just say that I know there's a lot of expectation about once the dental director's on and knows the ropes, that we can do some work on looking at the organization to try to improve the efficiency of operations. But if you could give a little update on that, that'd be great.
Sure, I'll be very brief. And to provide some additional context behind, I know that some folks have expressed some concerns. I mean, I have concerns about making sure we have a better product. I started in September of 2017, and shortly thereafter, there were some concerns raised that necessitated a pretty in-depth investigation into the program. That investigation, and due to HR concerns, I can't go into detail, but that did require us to make some significant changes to the department, to that particular program. And simultaneously with that, we did have a first effort. We did make a hire for a dental director, but the individual had to resign shortly after taking the position and starting the position for personal reasons. We re-advertised the position, and I'm happy to say that a conditional offer was extended and accepted, and just awaiting word back from HR on a start date if everything went smoothly with the final documentation. and very excited for the individual who will be starting and coming in and being able to give them some space to do some internal review. Now, we haven't actually waited for that person to start. We have been doing some internal review on our own, recognizing that there are areas that we can make more efficient and clean things up. One of those is looking at the leadership structure in terms of who reports to whom and how our staff is aligned. And so we have already made some preliminary changes to align the clinical staff in with one reporting structure, and then administrative staff to be able to report to an administrative lead. And each of those leaders would report to the dental director, who would have ultimate oversight of the clinical program. We have surveyed all of our providers as well to say what are problem areas and concerns that we can clean up. One such area is we're revamping the scheduling process. Historically, everyone got an hour, whether it's a cleaning, a more extensive procedure, and that's just not an efficient way to schedule. So we are breaking that down and setting up particular appointment types, and that is part of a larger effort where we are training the administrative staff in terms of how to better schedule patients. We're also putting them through or we'll be putting them through kind of a boot camp of sorts, a reminder in terms of how we determine and handle eligibility of clients who come in to use our services, the scheduling process, as well as consolidating some of those administrative procedures. For example, if folks need to call in for a question or appointment, there should be a central location as opposed to calling all 5 different spaces. We have started utilizing our utilization data from the electronic medical record to look at what level of services are offered at each of the sites, how frequently those services are offered, to look and say, well, does it make sense for service X to be here if it's only once a week, and we've got most of those services concentrated in another space. So again, we're utilizing data in a more strategic, savvy fashion. And the other component that I would say is we're continuing to move forward with establishing new partnerships with community providers. That is one of the things that I'm excited about the upcoming dental director. That individual does have a pretty extensive network with local and regional providers to be able to add to our resources. I'll be very candid. One of the things that does impact us and hamper our ability to be able to retain staff is the fact that none of our dental providers, with the exception of 2 hygienists, are county employees. And so that's something we're going to explore, how we can potentially create more opportunities to adjust that, because the reality is with all of our dentists as contractors, if one gets a new job with full benefits and extensive pay, I'm not mad at them for accepting that. They've got families to take care of. So that's another area where we want to explore in terms of how we can improve that process to be able to recruit and retain more folks within the system. So that's pretty much the perspective where we are.
And just for the previous HHS committee, Mr. Rice in particular, we had a lot of discussion around dental, and actually the council for a couple years added funding to try to increase the capacity because of the increasing knowledge about the link between your dental health and the health of your whole body. And so since we really hadn't seen kind of the increase in the people that were served commensurate with the money that was invested, one of the thoughts was that having a dentist who was a dental director, prior we actually didn't have a director of the services that was a dentist, would help with that understanding. And then I also would say the partnerships are really important because we do have like the Muslim clinic and Catholic charities. We have robust private providers. And so, how we can most efficiently serve the most people, since there are a lot of people who are low income and might be eligible for like Medicaid, but they still don't have any dental coverage. And so it is a very big gap in even for insured low income people to have dental coverage. So I think this is an area of interest. It's a big area of interest to the Montgomery Cares Advisory Board. I think probably when you met with them, they told you that they hadn't made a recommendation sort of pending this new work that's going to go on.
I just wanted to add one other thing to Linda's point too, is there's in addition to the inpatient clinical care, not inpatient, but the actual clinical cares, we recognize there is a room and space for education and outreach within the community. Just as important as outreach about STDs and HIV, we need to be doing more patient and resident education around dental and oral health. So the hope is that when we get the director in, we can be staffed up and get all those leadership positions filled so that we can start repurposing positions or looking at how time is being spent clinically, as well as being able to increase our opportunities to interface with the community.
And just the last area that I gave you some information on is environmental health and regulatory services. And so this is an area that there's only multi-program adjustments from a budgetary standpoint, but on the very last page on 16, I did give you a little bit of their workload data. These are the folks who go out and make sure that the swimming pools can open and the restaurants are inspected and there's no trans fats, and they take complaints about short-term rentals, and they just do a tremendous amount of work, and I think
Yeah.
sometimes it doesn't get
I know about the
highlighted too
pools.
often. So I did just want to give you just a little bit of an idea of the workload that they have.
Thank you.
That's for public health services.
I think no other lights. That concludes this particular work session. Thank you, everybody.